Thanks, Anga. That's why you're chief. Just kidding.
Everybody, thank you for joining. Let's start turning our cameras on, and we're going to have our first lecture with Dr. Chokshi, one of our rheumatologists, on scleroderma. Thank you. Whenever you're ready.
Okay. All right. Good afternoon, everybody. How are you all doing? Today's topic, we're going to talk about scleroderma. I know, you guys get a little bit of room on the floors, but not a lot, I think, compared to most other specialties, probably in terms of exposure and what you see. So I want to cover, I'm going to focus on the big things that you see as an internist in terms of what you should be looking for on the floors, as well as in the office, in the clinics, and your subspecialty practice. So this is an overview, guide to basic management, and some things to look out for that are mimics of scleroderma. So as you know, our autoimmune diseases affect every organ in the body from head to toe, and the same as it's with scleroderma, it can affect every organ system, and we'll touch on each of these. So what is scleroderma? It is divided into, first of all, what is scleros? Scleros means hard, indurated, and derma means skin. So by definition, sclerosis is circumscribed or diffuse hardening of the skin from fibrosis of the layers of the skin. It is a heterogeneous group of conditions, and there are thickened sclerotic skin lesions is like the prototypical classification for scleroderma, but as we'll talk shortly, that is not consistent with all subtypes of scleroderma. So it is sometimes a bit tricky. There are two general categories when you're studying for the boards. One is localized, the other is systemic. Localized is limited to the skin usually, whereas systemic can involve skin, muscles, joints, blood vessels, lungs, kidneys, heart, like I said, any other organ system. And the characteristic pathophysiology of scleroderma is widespread vascular dysfunction and progressive fibrosis of the organs and the skin. So the localized form is called linear scleroderma, which is most commonly presented in childhood, and usually encompasses one dermatome on one side of the body. And the most classic NBME picture you may see is a coupe de sabre, which is a facial or scalp lesion involving the skull. Morpheus is another type of localized scleroderma, which you may see. And it is one or more circumscribed isolated patches. If you can see here on this image here, it's localized as white, sort of hypopigmentation of area here, not to be confused with vitiligo. The skin is actually indurated and thick, but it can be a bit more diffuse and generalized morphea, which involves larger patches. And that can also involve the trunk and the limbs. And when you see a larger patch like this, you have to see if it's consistent with just morphea, which is localized, but it's also important to look for systemic scleroderma, as it can involve other organs, whereas morphea does not involve the organs. So there are other subtypes of morphea. Guttate, which are small papules, morphea profunda, which involves the fat, and bullous lesions as well. So there's many variants and subtypes of skin findings, which is where our dermatology colleagues can be of great help, especially with getting biopsies to help differentiate because of the way this can look similar to other conditions. Systemic scleroderma is the other subtype category, which can be, again, further divided into limited or diffuse. Limited versus Sinead sclerosis. The type of subtype that it is depends on the extent of the skin which is involved. So limited scleroderma, also known as Crest, is limited to the areas distal to the elbows and knees, sometimes can involve the face and neck, and it also has vascular manifestations. Contrary to that, diffuse scleroderma extends proximal to the wrist by textbook definition of diffuse scleroderma, and can involve the trunk, the chest, the abdomen, arms and legs. It can cause tendon friction rubs, and because it is more diffuse, what is happening to the organ system of the skin also can occur in the internal organs of the kidneys, lung, GI, and cardiac systems. Of note, the active diffuse scleroderma can progress quite rapidly. We're talking weeks to months in terms of disease progression, and their survival rate is lower. So it's important to also rule out concomitant malignancies. It has been reported very commonly with scleroderma compared to some of our other autoimmune diseases. There's a high risk of malignancy associated with scleroderma, so you do want to sort of look for that early on as an underlying driver of disease. So this is just a brief comparison slide again, whereas diffuse has lung fibrosis, which can be severe in 15% of patients. So does limited disease. Don't be fooled that limited disease only involves distal extremities in terms of skin involvement. It does still have the potential to cause scleroderma lung disease. The heart is more commonly involved with diffuse disease. The kidneys are also more commonly involved in diffuse disease. Joint contractures are more common with diffuse disease with friction rubs. And this disability, fatigue, pains goes along with the joint issues. This is important here. On this side, you'll see that although lung fibrosis can occur in both, it is more classic, interstitial lung disease more classically associated with diffuse scleroderma, whereas limited scleroderma is more commonly, by board questions related with pulmonary hypertension. And also an interesting finding, which is something to look out for, is transaminitis that correlates with the diagnosis of the disease, where you should rule out autoimmune hepatitis. In particular, of the different subtypes of autoimmune hepatitis, the one most commonly associated with limited scleroderma is primary biliary cirrhosis. So in the systemic form, the third subtype after limited and diffuse would be Sinead Scleroderma, which is very rare and challenging because it doesn't have the skin findings of classic scleroderma, but it has all of the other characteristic vascular and fibrotic features, Raynaud's, and the potential to involve and affect the major organs. So it's very tricky, but important to identify this and treat the patient the same way. There's also environmentally induced scleroderma due to certain exposures and chemicals and toxins in the environment. We'll touch on that later. And then scleroderma can be part of an overlap phenomena with other autoimmune diseases. For example, patients with lupus can have scleroderma as well. Dermatomyositis/myositis may overlap with scleroderma, rheumatoid, etc. So this is the 2013 American College of Rheumatology and the European criteria, the classification of systemic sclerosis. These are things that, this is sort of like a classification scheme you can use if you're concerned that somebody has scleroderma. It's based on a point system. 9 points classify somebody as likely having scleroderma. The sensitivity is 91% of this tool, and the specificity is 92%. Now, the 9 points you can get right away if you have the skin thickening of the fingers of both hands extending to the MCP joints. If you don't have that, or it's kind of hard to figure out, these are the other criteria include puffy fingers and sclerodactyly, which gives you 2 or 4 points respectively. Fingertip digital lesions, which gives you also 2 and 3 points if there's scarring. Telangiectasias, which gives you 2 points, most commonly to locate on the nasal skin area. Abnormal nail-full capillaries, which I'll talk about, gives you 2 points. Pulmonary arterial hypertension, or ILD, also gives you 2 points each. Raynaud's gives you 3 points. And the presence of one of the 3 scleroderma antibodies, the classic antibodies, gives you 3 points. So this, of course, doesn't apply for scleroderma mimics, which we'll talk about later. But that is the tool that we can use. Again, this is not a diagnostic tool. This is just a classification system, but these are the things that you would look out for that compose the diagnosis of scleroderma. So what are the antibodies, and what are the kinds of tests you would run on somebody if you suspected scleroderma? So the basic tests are very important. A CBC may pick up leukopenia, anemia, thrombocytopenia, especially if there's vascular phenomena going on. A creatinine is very important to check for renal disease or scleroderma renal crisis, as well as UA to look for CAS. And also, in terms of CBC, a peripheral smear can be helpful to look for schistocytes or microangiopathic hemolytic anemia if there's concern for scleroderma renal crisis. A CK may help to look for myositis if the muscles are involved. And the most specific antibodies, actually, a screening test, which we say we use a screening test. We start with screening tests first, would be an ANA test, anti-nuclear antibody. And we always say that you guys, you have two options when you're ordering in the office and in the clinics, in your clinics and on the floors. There's the ANA, and then the lab also has the ANA with immunofluorescence IFA pattern. We always ask that you send off the one with the IFA because it subtypes the ANA to how it actually stains under the microscope. And this is really important because there's many different types of patterns. Like once you click the result, if you had a patient, you'll see there's homogeneous, there's nuclear, there's speckled, etc. Speckled is very classic for scleroderma. Sometimes it gives it away. The other thing you'll notice, just as another pointer on the floors or in the office, is that our lab sometimes won't reflex the ANA to the scleroderma antibodies. It only does the lupus antibodies like double-stranded, Smith, RNP, and it won't report the scleroderma antibodies like SCL70, Centromere, and RNA polymerase 3. So speckled is a good indication that, especially if it's a high speckled ANA that comes like 1280 speckled, for example, that there's a hint that maybe you should go ahead and send off the scleroderma antibodies if you're having suspicion. So those are just some little pointers that you can think about. Another interesting thing, is that the more we investigate, the more we learn that there's a million antibodies out there for all of our different conditions, a lot which we're just discovering that target different parts of the cell and the nuclear material and the proteins. So some of these other antibodies that are reported in scleroderma include the U3-RNP antibody, which is associated with diffuse cutaneous scleroderma, and thyroid antibodies, which is interesting because sometimes you'll notice that patients with scleroderma also have autoimmune thyroid disease. And this could be another clue or something to look for or consider. Like oftentimes we have our patients who come with a history of Hashimoto's, and then, they have a positive ANA, and you'll see that the ANA can also be seen with positive thyroid antibodies, and therefore they have two autoimmune diseases. So these are all clinical tools or things you can think about if you're wondering if somebody has an autoimmune disease. These are some other antibodies that are coming out or being explored, which are experimental. So in terms of the three most common antibodies which show up on the boards, is the Centromere antibody is one of them, is associated with limited scleroderma, has a higher risk for pulmonary hypertension, as seen in 50 to 60% of patients. Then the topoisomerase antibody, also known as the SCL70 antibody, is more commonly associated with diffuse scleroderma, and that is reported with a higher risk of ILD. So you see that the antibody is not only important for the general diagnosis of the disease, but is also helpful for subclassifying the type of involvement that you think the disease will have. The third antibody is the RNA polymerase 3 antibody, which is associated with the rapid skin progression and more commonly associated with scleroderma renal crisis, and that occurs in 12 to 15% of patients. So we'll now briefly touch on the approach to the patient on presentation and long-term management. In terms of one, history is very important, and obtaining family history is included in this. Review of systems, we'll touch base on what are the different things to ask, what are the different exam findings to look for, what are some labs we already talked about, imaging studies we'll touch base on as well. What are the drugs we use? I'll go briefly into this, and what are the differential mimics? So, history. the chief complaint can be so varied because so many different organ systems can be involved. It can be anywhere from skin tightening to Raynaud's to dysmotility, GI issues, to, a patient is saying they're comatose in the ICU. That's the consult you get on the floors. And you have to sort of, in that case, you just have to sort of tease it apart from what's available in the chart and on your exam. The incidence in the US is 9 to 46 cases per million per year. The peak onset, unlike some of our other diseases, actually older population, 65 to 74. And I'll say that in the last, now that we're living longer, we're seeing that a lot of our diseases are occurring or being diagnosed or, manifesting in patients who are older. So just because somebody's, 70 years old in the ICU intubated doesn't mean they can't have scleroderma. There's a strong female predominance, 4.6 to 1, especially during the childbearing years, which can be challenging in terms of management. There's a risk factor with family history and first-degree family members. There's a 13-fold risk of developing disease. So family history is very important. And also these patients, like I mentioned, can have other coexisting diseases like lupus and rheumatoid. And all of these sort of fall on certain gene loci as well, which is being investigated. Certain races are higher risk of developing scleroderma, more Caucasians, USA or Australia compared to Japan and Europe, and Blacks more than whites, classically reported in the literature. Younger age of onset, more diffuse disease, ILD, and worse prognosis occurs in certain groups of populations as well, based on genetic factors. So the survival rate, 5-year survival rate for systemic scleroderma is 85% actually, despite everything that I sort of just said. And the 10-year survival rate is about 70%. So it is something that patients sort of have as a chronic disease that needs to be managed, just like our other chronic diseases, like, for example, diabetes. Diffuse scleroderma, however, does have a poor outcome than limited scleroderma. And the major causes of death in persons with scleroderma are pulmonary involvement, in particular pulmonary hypertension and fibrosis, scleroderma renal crisis, which is pretty rapid onset and acute in terms of mortality, and cardiac issues. So these are the kinds of things you sort of want to screen for long-term in your patients from visit to visit. And then, of course, the association with lung cancers is important. In particular, liver, lung, hematologic bladder, and tongue cancers are the most commonly reported. So just briefly touching on the pathogenesis of the disease, there's a high incidence of ANA in first-degree relatives of patients, and the presence of HLA genes, that's where the risk is carried on in terms of genetics. And the presence of antibodies is an important tool. And what are some actually environmental non-genetic triggers of scleroderma include viruses. We know that a lot of viruses, in particular EBV, CMV, are known to trigger autoimmune diseases like lupus and scleroderma. And there are some reports of dietary factors, as well as chemicals, occupational risks and hazards, certain types of toxins can cause, all of these things can cause damage to the DNA and trigger off the cycle for scleroderma. And some of the drugs that are commonly reported to cause the disease include bleomycin and cocaine, as well as radiation, certain supplements. And this I kind of just put on here, that gadolinium-induced nephrogenic systemic fibrosis can mimic scleroderma in terms of skin findings, but is a different thing to consider. And that's also where history sometimes comes in. Ask a patient about why they may have some new skin findings. So all of these exposures cause free radicals, which damage vasculature and cause endothelial injury, which affects the T cells, B cells, and macrophages, producing antibodies, which then affect different organs. The endothelial cell injury releases vasoactive mediators, which can cause vasculopathy, and endothelial cell proliferation and hypertrophy, which are the systemic vascular manifestations, such as Raynaud's that manifest. Also, the vasoactive mediators can increase fibroblast activation and accumulation of collagen, which leads to the fibrosis. of the skin and organs, and also the chemicals and chemokines and cytokines that then affect the immune system cells to basically cause the threefold injury to the body in terms of microvasculopathy, immune dysregulation, and fibrosis as a cornerstone for systemic sclerosis. So we kind of touched on the different multi-organ involvement, and I'll kind of go into each of them individually. So musculoskeletal wise, patients complain of fatigue, arthralgias, myalgias, pain related to the discomfort in their joints, Raynaud's, or digital ulcers, and generalized just fatigue and sleep issues. The management for musculoskeletal features includes NSAIDs, short courses of steroids. We'll talk about that later, that higher doses of steroids can trigger scleroderma renal crisis. DMARDs such as hydroxychloroquine, methotrexate, azathioprine, which are typically the three that we use for autoimmune joint arthritis. Physical therapy is key, as well as surgery if there's significant disease burden leading to joint contractures or dysmotility or immotility of the joints. The cutaneous features are variable and can depend on the extent of disease skin involvement and the severity of it. So any area, as I mentioned, can be involved. Fingers, hands, the face can present with sclerodactyly, morphea, edema, erythema, pigment changes, hair loss, digital tip ulcers, telangiectasias, calcinosis cutis, and acrosteolysis. So here I'll have some pictures of, this is a scleroderma sort of skin appearance. This is the puffy hands, quote unquote. You can see sort of this mottling kind of salt pepper appearance, as our dermatology colleagues like to call it, which can then progress to sort of sclerodactyly and contractures where this patient is unable to actually extend their fingers. And then chronic contractures, unfortunately. This you can't see very well, but it's showing like a lacy reticular mottling of the skin of the palms, which sort of goes along with the vasculopathy aspect. Here you can see signs of some digital ulcers, which can get quite severe and result in auto amputation of the digits in patients, which is obviously serious in terms of basically losing fingers. Telangiectasias, nowadays you have to ask the patient if they're amenable to taking off their mask, so you can actually look at their nose and their malar rash and their face for a lot of our skin conditions. You don't want to miss this. Plus, you'll see that the orifice is decreased in size for this patient. They'll say they have a harder time opening their mouth wide to eat because there's skin thickening and tightening here that prevents them. And you can also see loss of the wrinkles of the forehead. They're 70 years old and they don't have any wrinkles. So when you ask them to raise their eyebrows, the skin is very shiny and flat and young looking, but it's not. It's sclerosed. And then you can see similar here. You may see loss of the DIP folds of the skin that you and I would have, for example, because of the thickening of the skin of the fingers. Telangiectasias, like I said, can occur anywhere. The skin is sort of a mirror of what's going on inside the body, as we'll discuss. So you can see it on the lips as well, to look inside the mouth, as I mentioned. And then calcinosis, calcium deposition, can occur under the skin and anywhere. And patients may report that they have these lumps or bumps under their skin. So this is important to sort of examine the patient. Sometimes you'll notice things that they've never noticed. You'll be surprised. Patients sometimes don't know they have a malar rash, or they'll say they just get flushed, or but then you have to ask them, and you can sort of sometimes pick that up. So the modified Radon score is a tool which we use more in clinical trials and sort of experimental, like different experiments for monitoring treatment for scleroderma. but it is a measure of the thickness of the skin as normal, mild, moderate, or severe across 17 sites from head to toe. We don't have time to do this in the office for sure. So, but this is sort of the concept of how to monitor response to skin, response to treatment in terms of the skin over time, and also look for progression visit to visit. So the management of skin disease. So diffuse skin involvement, but no visceral involvement. You can use agents such as methotrexate, mycophenolate mofetil. You kind of don't use, we've tried to avoid cyclophosphamide for most of our diseases until something is pretty advanced or, life-threatening or end stage, or they sort of failed a lot of other drugs or treatments. But that is something that is also reported. There's a lot of debatable data out there in terms of skin disease. A lot is from the dermatology world, which is really good. We like to get our derm colleagues involved early on. So we've tried IVIG, we've tried rituximab for refractory cases. Topicals also can be very helpful. For example, tacrolimus is topical corticosteroids. There's new data on like JAK inhibitors. So there's a lot coming out that we sort of, when patients are at the risk of, for example, autoamputation or, severe skin involvement, this is all something that we kind of have to sometimes just try on our patients to see if they'll get some relief. Light therapy and laser therapy can also be used for telangiectasias. Patients are very conscious of their skin. That's like their biggest complaint sometimes. So you do have to sort of address that. And then for calcinosis cutis, you don't want it to get worse. You want to improve circulation to the extremities. And some of these medications, last resort would be surgery, especially if there's risk of abscess or ulceration of the digit and superinfection, because these patients are, of course, immunosuppressed as well. So the vascular manifestations are also very important. The most classic presentation association for both systemic and for both limited and diffuse scleroderma is Raynaud's phenomena, which is by definition sequential color changes in the digits precipitated by cold, stress, or changes in temperature. It is basically pathophysiologically a reversible arterial vasoconstriction in the digits, where the digits change from white to blue to red. As there is vasoconstriction, there's loss of blood flow to the extremities on cold exposure, so the extremity appears white with vasospasm. Then with the lack of oxygen, it starts looking blue or dusky. And then as the patient heats themselves up or they go indoors, the flow returns and the digit becomes hyperemic. That's the classic triphasic discoloration of Raynaud's. These days, patient will come in. A lot of patients already know what Raynaud's is, or they have friends or family with Raynaud's, or they sort of just Googled and self-diagnose themselves. Just as an FYI, primary Raynaud's can occur in the general population of healthy people who don't have scleroderma in numbers as high as 10 to 20%. So it doesn't automatically mean they have scleroderma per se, but it is an important thing to ask and an important thing to monitor because of this progression that we don't want to see in the most severe cases of digital ischemic ulcers. And the other important vascular association seen in a lot of our autoimmune diseases is thrombosis risk. This thrombosis risk is in and of itself due to the pro-inflammatory cascade, as well as hypercoagulability and thrombosis that occurs in the blood vessels. But one more thing you have to think about is something like antiphospholipid antibody syndrome, which may often overlap with a lot of our diseases, and something to check for. And a lot of our patients, their initial manifestation might just be a P or DVT, for example. So this is important to screen for. I was mentioning before nail fold capillaroscopy. This is a cheap tool you can use in the office and carry a dermatoscope. Basically looking here at the proximal nail fold for changes. Sometimes it's so severe or so obvious that you can see it even without the dermatoscope. But under the dermatoscope, you may see different stages of the vessels, the capillaries that feed the nail bed being inflamed to the point of basically, having angiogenesis and dropout. So this is a cheap but important tool to use, which is a reflection of what's actually going on systemically affecting the organs. So what is the management for Raynaud's? First is primary conservative management, double glove, double sock, hand warmers, feet warmers, scarves, protect the ears, etc. Vasodilators and medications can also be used, sympatholytic agents, prostaglandins, endothelin receptor antagonists. We usually start with calcium channel blockers, but sometimes patients become hypotensive or they get leg swelling. Then we have to think about other options like PDE5 inhibitors, topical nitrate creams locally. Sometimes patients cannot tolerate or handle these medications. So we'll try local treatment, especially when there's, distal digital like ischemic involvement, and even botulinum toxin, botulinum injection, which is why we often refer to our dermatology colleagues. So what are the GI involvements of scleroderma? GI-wise, 90% of patients with either limited or diffuse scleroderma have GI involvement, but 50% don't even have symptoms yet. It can affect any part of the GI tract, and there's many different manifestations depending on which part of the tract is involved. It can cause esophageal hypomotility and a dilated esophagus, which may sometimes, in our office, we have sort of make diagnoses, not based on the patient's complaints of GERD and dysphagia, but rather we're screening a CAT scan for ILD and we see a dilated patulous esophagus. You may have seen reports of that. So that's a pretty cheap, that's a tool that CAT scan is a tool to assess the GI system in a way, and it's helpful. Lower esophageal sphincter hypomotility. A lot of these patients have esophagitis and strictures, Barrett's esophagus. They get pulmonary microaspirations due to their reflux, which can be pretty severe sometimes, which then exacerbates their ILD as microaspiration, which is challenging. Constipation and diarrhea sometimes can be so severe, with abdominal symptoms and requiring surgeries, and pseudo-obstruction sometimes. Small bowel overgrowth and malabsorption is a problem, and sometimes the GI colleagues will prescribe antibiotics, also for motility. GAVE is a tricky diagnosis, but very important, with quote-unquote watermelon stomach, which is vascular ectasia as part of the vascular manifestation of scleroderma GI disease. I mentioned to you autoimmune hepatitis involving the liver, causing primary biliary cirrhosis, where you would send off the autoimmune hepatitis antibodies. And of course, the pancreas can also be involved, causing pancreatic insufficiency. What is the management? GERD management is key. Sometimes patients don't even know they have GERD until you explain it to them or you describe the sensation of GERD to them. And then they say, oh yes, I do have that. Proper diet management, not eating late, taking your PPI properly according to the instructions on the packet is very important. And then you will see, we have some patients in our clinics here, you've probably seen them if you're a second, third year by now. Some of these patients are pretty severe GI disease where they've had surgeries or they keep getting admitted, or now they have PEGs. So that's, they've had repeated dilations, etc. We've had several consults and patients on the floors like that. So that's important. Prokinetic agents such as Reglan and erythromycin, octreotide, are things our GI colleagues may consider. A lot of these patients are super infected, so antifungals are important for Candida. For GAVE and telangiectasias, the GI may consider laser heater RFA. For small bacterial overgrowth, we treat with antibiotics. Laxatives are helpful for constipation and bulking agents if there's overflow, stool incontinence. Ursodiol is used for primary biliary cirrhosis, and for pancreatic insufficiency, we use enzyme replacement. What are the cardiac manifestations? So cardiac involvement portends a poor prognosis in scleroderma. The 2-year mortality is 60%, and the 5-year mortality is 75%. So 3 out of 4 of your patients with scleroderma who have cardiac involvement will not be there in 5 years. That's pretty serious. So you want to sort of screen this early on, refer to your cardiology colleagues, and optimize these patients from the cardiac/pulmonary standpoint. Cardiology referrals is also helpful because they can help diagnose pulmonary hypertension along with the pulmonologist with a right heart cath. Pericarditis and pericardial effusions, as well as myocarditis and myocardial fibrosis can also occur. And we have a lot of great radiology/cardiac imaging tools available now, like cardiac MRI, CT coronary, a lot of screening tools to assess the heart and the pericardium without a cath, because you'll see that a lot of these patients, the cath will come back clean, and yet they're having chest pain. So you want to sort of screen for this. I mean, here's an example of a biopsy that shows fibrosis of the blood vessels as well as the muscle tissue itself. We're not probably going to do a muscle cardiac biopsy to diagnose a patient with scleroderma or to prove they have cardiac involvement, but you can suspect that most patients who have systemic vascular disease will have cardiovascular disease as well. Arrhythmias are also reported in our patients. You'll see both as, for example, atrial fibrillation, a flutter related to underlying pulmonary disease, but also related to the actual conduction system of the heart being affected with fibrosis or ischemia. CHF is commonly reported in our patients, which you have to sort of separate out from, for example, woody scleroderma legs with edema. You have to separate that out. And coronary vasospasm, which is challenging. You have a 30-year-old patient who's complaining of chest pain with but a negative cath, for example, or borderline tropes. You have to screen for these kinds of things. Management, of course, got to echo early on. Pericardiectomy and pericardicentesis. We've had consults here with patients with scleroderma or autoimmune rheumatologic disease have had 1-2 liters of fluid drained in the CCU. And BP meds, diuretics, CHF meds are optimized from that standpoint. With major organ involvement like the heart, they do need to probably be on immunosuppressant. Selection depends on the complexity of the patient, and they may need an AICD or defibrillator. Renal involvement. So renal involvement is present in 60 to 80% of diffuse scleroderma patients on autopsy. And it's a composite of vascular fibrosis and collagen accumulation in the renal vasculature system. A scleroderma renal crisis is by definition a rheumatologic emergency, but nowadays I'm coming to realize that everything here is a rheumatologic emergency, so I don't think it's special anymore. It occurs in 10 to 15% of patients, and diffuse scleroderma is more commonly associated with scleroderma renal crisis than limited scleroderma. What are the things to look out for? When do you think about scleroderma renal crisis? One is abrupt onset of malignant hypertension that's refractory to treatment. You have to start looking for hypertensive urgency and emergency signs and symptoms. The patient may have AKI, acute onset renal failure. Some of these patients end up on hemodialysis, like almost immediately once admitted. The UA is a very good tool. You can look for protein with few cells in CAS. It may not have like the, significant RBC, white blood cells, like significant protein, like you may see, for example, in a lupus nephritis patient or ankle vasculitis patient, but it is a good thing to check for. Like I told you before, in terms of microangiopathic hemolysis and thrombocytopenia, you can get your heme colleagues involved to look at the smear and to trend these lab parameters, because that's pretty classic for scleroderma renal crisis. And the trigger and the risk, in fact, the odds ratio of 4.47 is with steroid use of greater than 15 milligrams a day. And this is one of our diseases, unfortunately, where we have to be super cautious about using the steroids. With everybody else, we say, go ahead, pulse them. Lupus nephritis, diffuse alveolar hemorrhage, lupus cerebritis, like these are other rheumatologic emergencies, for example. We say, go ahead, give them a gram. These patients, unfortunately, our hands are tied. We can't give them 1,000 milligrams of prednisone or steroid. We have to be using as minimal as possible, less than 50 milligrams a day, to avoid scleroderma renal crisis and sort of be cautious and careful. So it's not that easy. So what is the treatment? I'll talk about it, but it's basically an ACE inhibitor, captopril. And some of these patients are actually on a drip in the CCU or ICU to sort of monitor that and bring down the blood pressure gradually. What are some other things? You can call ophthalmology to look for retinal hemorrhages. There may be flash pulmonary edema, hypertensive encephalopathy, all the signs of hypertension emergency. Of note, which antibody is most commonly associated with scleroderma renal crisis would be the RNA polymerase 3. I don't know if that's a board question these days, but that's something to remember and sort of be cautious about. It is rare, but it is reported to have glomerulonephritis and ankle vasculitis as other manifestations of scleroderma renal crisis. What is the management? Like I said, it's a rapid disease with progression to death in less than a year. I wouldn't say even a year. A lot of these patients, die in that admission. It's very challenging. They can sometimes be transferred for transplant, but you may not have time, or they may not be stable enough for the transfer to an outside institution at that point. And captopril, if in doubt, and no reason not to, if you're choosing which hypertensive agent to choose for this patient, then just start it. And be careful about how much steroids you get. Pulmonary involvement occurs in more than 80% of patients with scleroderma. As you can see, a lot of these major organs are involved in patients with scleroderma, so it is definitely beyond the skin, okay? Pulmonary hypertension, pulmonary artery hypertension occurs most commonly with Crest, like I said. It is associated with the Centromere antibody, and symptoms can be varied from asymptomatic to shortness of breath, dyspnea exertion. Interstitial lung disease occurs in 50% of patients with diffuse scleroderma and 25% of patients with limited scleroderma. It is most commonly associated with the SCL70 topoisomerase antibody. And again, the symptoms are varied. And a CT chest is a good important tool. You want to try to get early on in HRCT. There's a lot of data that's coming out now that why wait for your pulmonology appointment to have that CT be ordered and then follow up again. There's a lot of data that's sort of pushed now by some pulmonology recommendations that the rheumatologist should just go ahead and order the CT to screen for this early on, especially because you have to understand patients are asymptomatic, and a chest X-ray can be limited. So sometimes if I know how hard it is sometimes to get your subspecialty appointments, including of course rheumatology, sometimes in the interest of time, I'll go ahead and order the scan, and it will come back as something so that the pulmonologist has that on their evaluation. Other important pulmonary manifestations include thromboembolic disease, pleural disease, pneumothoracic aspiration, drug-induced pneumonitis, and lung cancer, like I told you, as a higher risk in scleroderma. So the management, what is it in terms of testing? You can start it with the cheap chest X-ray. PFT is assessing lung volumes. The key is a reduction in the DLCO. That is a good indicator, as well as a reduced total lung capacity, or FVC. So the two key tests, if I were to say what you want to order and look for, would be a PFT and HRCT. The presentation at HRCT are varied, from Gern-Glass opacities to emphysema to honeycombing. It can be either a non-specific interstitial pneumonia NSIP pattern, or it could be a usual interstitial pneumonia UIP pattern. So it might not be too clear, but that's what the pulmonologist can help with. Echo is a good screening tool for pulmonary artery hypertension, but it may not be enough. You may need a cath. Bronch there's concern if you want to get a biopsy, if you're concerned about underlying lung tumor, or if you're concerned about compromising infection superimposed on a patient with ILD because they've been on immunosuppressants. And VATS may not be diagnostic, but if you have nothing else, may be helpful. So the treatment of pulmonary hypertension has evolved significantly in the last few years. We have our basic prostacyclin agonist, endothelin antagonist, nitric oxide enhancers. PDE5 inhibitors, calcium channel blockers, and pulmonary rehab options, smoking cessation, etc. These are all important. Last resort is lung transplant, not available to everybody, especially if there's other organ involvement, but an option. And something to sort of think early on if somebody's disease is really refractory or progressive. And each of these I won't go into, but targets different pathways to help with vasodilation and pulmonary hypertension. And there are different categories of pulmonary hypertension. Because scleroderma patients are so complicated, it may be one or more categories overlapping, and the choice of agent may depend on the workup that's done and the input from the cardiologist and pulmonologist. So here's some imaging findings. This classic ground glass, bronchiectasis, bilateral or unilateral involvement, even dilated esophagus on X-ray I told you about. These are all things to look for. Here, you can see that. So interstitial lung disease, again, you want to start treatment early. The FVC declines rapidly sometimes. Mycophenolate is the agent of choice. Cyclophosphamide if things aren't looking so good. Azathioprine is another possibility. We do have patients with scleroderma on steroids if they have ILD. It's not like we can't use it. We just have to be careful how much. And then our biologics and our pulmonary hypertension management and the new drugs that are coming out or being used for rheumatoid are also being used for scleroderma. Hematopoietic stem cell transplant is also in the works. There's some data on that. Some promising data, some not so promising data, but definitely something interesting to think about, and referral to tertiary center if your patient isn't doing well. Briefly, scleroderma can affect the CNS or the PNS systems. You want to be sure and assess for these kinds of things if there's a acute change in your patient status. It can affect the GU system, which can be quite bothersome or debilitating in terms of, psychiatrically for some patients. It does affect their way of life. You have to think about, I didn't talk about scleroderma in pregnancy, but these are all psychosocial aspects of the patient and their disease process that, is probably a whole nother lecture in itself. The differential, briefly, for the boards, scleroderma, not scleroderma, is symmetrical skin thickening, predominantly on the trunk, shoulders, and upper back, and the face, where the fingers are spared, which is not classic for typical scleroderma. And they don't have the other manifestations. Then there's scleromyxedema, which is papillary mucinosis, some endocrinologic disorders, such as diabetic arthropathy, prayer sign, which improves with proper diabetic management, nephrogenic systemic fibrosis with MRI studies, eosinophilic fasciitis. This is, again, another tricky autoimmune diagnosis sometimes. That's why skin biopsies are very helpful, because you will get the eosinophilia on the biopsy, and that affects management. Graft versus host disease, drug-induced diseases I mentioned, and environmental exposures. And that's it.
Thank you, Dr. Chokshi. Any questions from anybody?
I guess I just have a comment, because recently I saw a patient who she was admitted to the CCU because she had a pericardial tamponade and she had a history of scleroderma. And it was funny because we saw her when she came to our service, like her blood pressure was like 200s over 100, and she had an AKI. So we were like, oh my God, this is a renal crisis, it's an emergency. But then we saw that basically she has been with high blood pressure for months, like in the 200. But yeah, we put her on the capture pill, and I didn't know about that. We couldn't use a steroid. So, but yeah, it was like a good learning experience. And also, I remember that patient, like, she uses cocaine, and they found cocaine like in her room as well. So it was like, yeah, I see like so many things that I got to learn with her. Yeah, for sure.
Just to clarify, she said, I don't use cocaine. I just take tablets with ecstasy. So make sure you document that properly about her. Yeah, I saw that patient. That was a good case. That was interesting.
Yeah,
First,
yeah.
she was taking her Cellcept improperly. She was only taking 3 tablets instead of 6, first of all.
Oh,
That could have contributed to her flare. 2, she was taking cocaine, which doesn't help with blood pressure. 3, she doesn't follow up very well. But yeah, she had very classic symptoms. And that's a good point because I was debating that myself. If she hadn't gotten out of the ICU and the fluid had accumulated on the repeat echo, my question was, should I be able to treat her with a little bit of steroids to help bring down the inflammation in the myocardium and her effusion? But you're right, this whole scleroderma renal crisis, to be honest with that patient, there were a few things that could have been checked. For example, UA, peripheral smear, right? She didn't really have thrombocytopenia. She really didn't have microangiopathic hemolytic anemia, which is kind of because of that recent patient. I did emphasize those points in my PowerPoint. These are some things you kind of want to get worked up properly because it affects how we can treat it and what we choose to treat it. But in the end, she did go home. And, hopefully she'll follow up and take her medicine properly and stop taking cocaine tablets. So, questions? Does renal crisis usually present in people with known scleroderma, or how many patients present in renal crisis as their first presentation? So tricky, good question. Because first of all, like I just said, it's hard to diagnose that somebody has renal crisis. It does present in people with known scleroderma, but it can be their primary manifestation, especially if they're undiagnosed or they don't see the doctor, or it's rapidly progressive, which can happen with the scleroderma renal crisis. Second question. So captopril is the only ACE inhibitor that we can use. No, not the only ACE inhibitor that we can use, but the agent we prefer because it's titratable. It's IV, it's rapid onset, and the infusion can be turned on and off in the ICU. And these patients, the blood pressure and the kidneys have to be closely monitored. So that's one of the reasons we kind of go for captopril. What is the disease course for most patients after starting treatment? Do they improve much? Good question. Like all of our diseases, patient dependent. Some patients are very mild, some patients are very severe. Some patients have incidental scleroderma antibodies because, we just send off ANA and then the scleroderma antibody comes back, but they don't have any signs or symptoms of scleroderma. I did have one patient like that. And the scary and sad thing for those kinds of patients is then they go Google it and they read about scleroderma and they get really nervous and anxious and scared. And then they ask you if they're going to live. So, and then they're like 20 years old too. So it's a bit of a challenge. First of all, how they will do. And what is the clinical utility of, these tests? So what is the disease course depends on whether they have limited or diffuse, the extent and type of organ involvement, whether they are compliant, follow up and take their medications, and how aggressive do we choose to treat them. So before I'd say that it was a bad diagnosis, I think, when I was going through maybe med school, we didn't really have too many options for scleroderma in terms of medication options compared to some of our other diseases. But I think over the course of the years, we've come to realize that there are many new pulmonary hypertension drugs. We have a lot more biologics now. Patients are pretty good about, following up and treating their diseases. So I think outcomes can be good and patients can live with this long term.
If no more questions, thank you so much for joining us, Dr. Chokshi. That was a great lecture.
For having me. Wish you all the best.
Thank you. Bye.